Yes, we can see your screen.
Sir, thank you, sir. So today I will be presenting, sir, with your permission, I will be presenting OCT guide management.
So let me do the introduction and then I'll hand you over the podium. Okay.
Sir, yes, sir. Yes, sir.
Yeah, just. So good evening, everybody, and very warm welcome to our PCI Conclave, episode 8. And we have with us our national expert, Dr. Shubhanan Roy. He needs no introduction, but as a moderator, it's my job to introduce him. He's a renowned interventional cardiologist in Eastern India and nationally as well. A friend of mine, and he has more than 25 years of experience. And he's a specialist in complex interventions, including left main stenting, rotablator, intracardiac imaging, FFRs, bifurcation stenting, and CTOs, primary angioplasty, TAVIs, and thrombus-containing lesion. He is also well versed in peripheral carotid and renal angioplasty. Has numerous publications in national and international journals, and also involved in many path-breaking clinical trials as a PI. And also he has his own technique, which is actually shared by many operators globally now, and then the crush technique, which he will discuss later on. And we have with us three very esteemed speakers today in Dr. I.S. Monga, who is a senior interventional cardiologist at Command Hospital, Kolkata, with more than 15 years of experience. And his interest is mainly in imaging, physiology, and complex coronary procedures. I was just going through one of the journals where he published very interesting data on these patients with young patients with acute coronary syndrome, how how OCTs actually saved the day. So he may be discussing on few of those cases. We also have with us Dr. M.J. Azam, who is Associate Professor and Department of Cardiology at the NICPD Dhaka, and also Dr. Shumant Chatterjee, who is a Senior Interventional Cardiologist at Amri Hospitals, Dhakuria, Kolkata. So with this, let me hand over the podium to Dr. Shubhanan Ray as an expert, and also the speaker, Colonel Dr. Inderjit Singh Monga. And he's going to discuss about OCT-guided management of recurrent late stent thrombosis or failure in patients presenting with ACS. Over to you, Dr. Monga.
Good evening, sir. Thank you very much, sir, for giving me an opportunity to present my case, sir. Actually, this patient had is a 72-year-old male. He's a non-smoker, hypertensive, non-diabetic. He has numerous interventions done in the past, sir. He's a known case of coronary artery disease, old inferior valve MI, triple vessel disease. He underwent first stenting to the LCX and to the LCX to OM2 in 2014, followed by RCA in 2016, then PCI to PLV in 2019, followed by PCI to LED in July 2020. I've got record of this stent, sir. He had put in two stents, Ultimaster 2.524 and 2.512. And this was followed by, he had another event of ACS in April this year only, sir. And he was found to have LED ISR of close to 90%, sir. After that, he underwent one DAB in this hospital only, Command Hospital, 2.75 into 15 magic touch. And last EF documented is 50% with inferior posterior valve hypokinesia. So this patient landed with me, sir. I joined in 1st of August, sir. This last month only I have joined, sir. So this patient had presented to me in acute LVF. He came to us in emergency and on 31st of August. But his ECG showed dynamic T-wave inversion and it was suggestive valence type B pattern, and his tropi was positive. And echo suggestive of previous echo is 50% EF. Now it has come down to 30 to 35% with anterior valve hypokinesia, which was new. However, thickness were preserved. So initially, patient was managed with NAV support, diuretics, and antibiotics in the ICU. After that, sir, I had taken after stabilization. Next day, I had taken him for angiography, which showed ISR again. 99%. This was the ECG on presentation. So he had sinus tachycardia and he had deep T-wave emergence in the anterior leads and with poor RV progression from the previous ISR. So this was the check angio initially, which I could get it from the patient. And when he came to us last in April 2023, I was not there. I was in Chandigarh at the time. So he had ISR of close to 90% here, 90% in the mid LAD. So he underwent POBA first by 212 and followed by 2.512 balloon. And after that, he underwent depth to the LED ISR with 2.75 into 15 millimeter magic touch. This was the final result when the operator stopped the procedure, sir. And now, in between, patient was coming to OPD, but this time he landed with acute LVF. So this was a ECG, this thing, angiography. When I took him after stabilization on the next day, sir, this shows mid-LED, same place where POBA was done and TEB was done, same place, and calcium is also there. There is a new ISR of 99%. So I first started with imaging. Last time they didn't do the imaging. So I first ran crossing with the wire, then immediately took a OCT pullback. And after that, starting with the pre-dilatation, sir, first with the 2 into 12, 2 into 10 millimeter scoring balloon, and then with the 2.5 into 15 millimeter scoring balloon. So this was the OCT, initial OCT run, sir, before taking any pre-dilatation. So we can see the sensor and ISR. First is homogeneous, thereafter it is becoming heterogeneous, and a lot of calcium is behind the stent. So it's an underexpanded stent with a lot of calcium behind. And stent, inside stent also there is calcium spots. Here also calcium is there. So there is homogeneous as well as heterogeneous ISR, and with some plaque rupture. Behind the stent, we can see the calcium. That may be the reason of underexpanded stent. So after this, I first dilated this patient LED with 2.75 into 15 millimeter of cutting balloon. Thereafter, again 2.75 12 NC balloon was taken because of inadequate expansion was noted. So I did the entire sensor. And after that, still since under expansion was there at this place, so I used this 3 into 12 millimeter IVL balloon. As we have seen that reason for underexpanded stent was one of the reasons was behind the studs also there was calcium. So we tried to do all the 80 pulses were delivered here in this part, sir, and in the proximal part also. So after this, I did the OCT pullback again, sir, to see how much expansion I have achieved. So there are a lot of cuts because of cutting balloon and scoring balloons, and we can see stent expanded little better, and we got some luminal gain, but this is not adequate. There's a lot of calcium behind the studs also. So this is underexpanded stent. So after this, I deployed the 3 into 19 mm VVS for this patient ISR, and then post with the same overlap portion also with the same balloon. And after that, 3.25 into 10 balloon I used for post dilatation. Then took the OCT run again, sir. This time we noticed we took it from little far away, sir, because there was a lesion here also. So we could find out a lot of calcium there also, and there are places where there is a dissection. I have not used any balloon here. So we can see there are dissected part there. So after that, we can see the BVS studs here, sir, with some part of thrombus is also common. So gave intracoronary ReoPro on this, and further we can see that some studs are still not dilated, sir. There is malopposition. So after this, I first did the DEB in the distal part where I found some dissection was there. And after that, sir, I did the 3.5 into 10 post dilatation. I didn't take the fourth OCT run because patient already got severe LV dysfunction. So I didn't want him to land in failure again. After that, patient was shifted to CCU and stabilized and discharged on 3rd. Check angio is planned after 6 months. So take-home message from this case was that calcified neocytosis and underexpanded stent due to calcium behind the stents was diagnosed in this patient who's coming with recurrent stent failure using OCT, And patient with severe limitation, OCT can be done with low contrast. That is with 1:1 dilution. That's what we followed in this patient. And patient was finally optimized using cutting balloon as well as IVL, and BVS was implanted. So in last 10 cases, sir, I've started implanting BVS. Sir. I have to yet to see the result after for these neo stent failure patients. And OCT thus helps in managing a case of recurrent stent, late stent failure and underexpanded stent with calcified neothoscosis. So that's all from my side, sir.
Thank you, Dr. Monga. I think this is a wonderful case for discussion. I'm sure Dr. Shubhanandre will have a lot of points to discuss, and then I can add in my points. Doctor, over to you, Dr. Ray.
This is a very good case, an excellent case for discussion, as you have said. And first point is why you call it a calcified neoatherosclerosis. It is a neoatherosclerosis which is on an underexpanded stent due to calcified calcification. Perhaps the diagnosis would be like that. If you look at the ISR of drug-eluting stents, you will see that in a bare metal stent, the ISR is mainly homogeneous and due to neo-intimal proliferation. But in a DES, neoatherosclerosis is a major part, because in a bare metal stent, neoatherosclerosis happens after 10 years, whereas a drug-eluting stent, the neoatherosclerosis begins 1.5 years. So this basically is this, and neoatherosclerosis is just like an atherosclerotic plaque, and there is a plaque rupture, and the patient presented with acute coronary syndrome. And the point is, this patient had a DEB. After that, you have put some BRS. Then the major point to be discussed here is the imaging. You did the right thing to do the image in the beginning, because all the ISR cases, drug-eluting ISR cases, should have an imaging done. And in most of the cases, then ideally is OCT. We know that IVAS is also a very good imaging technique, but in ISR, all the recent classification is based on OCT findings, because OCT can determine neoatherosclerosis and also lipid-laden plaques in the ISR very well, and much better than IVAS. And particularly in cases where there is a calcium, the IVAS is really cannot give you the right perspective, because the calcium will produce a negative shadow, there will be blackening, so you cannot assess the size of the vessel very well. So OCT there is a very good tool to begin with. So from the first learning from your case, we have learned that you must begin with an imaging, and particularly OCT. The next is an underexpanded stent. What is an underexpanded stent? If the stent area there is less than 5 millimeter square, then it less than 5 millimeter square, that is 4, 3, 2. So this is underexpanded. And mostly the underexpanded stents are due to calcium on the background. And you have done the second right thing to take an IVL. 3 millimeter IVL, maybe a little larger would have been much easier or better, I don't know. But 3 is okay. You have taken a good IVL, and then you have to attain a size of 3.47, that is 3.5. Because in OCT, in IVAS, the vessel size is overrated. In OCT, it is equal, and angio, it is underrated. So if you see a 3.5 millimeter vessel, you need to go at least up to 3.5 millimeter. We have learned that. That is when there is a very dark, deep calcium around the stent, which is preventing the stent to expand, we must take an IVL. That is the best tool here. Number 3 is the BRS. Though with the debacle of Absorb, BRS have been out of the market, There are also some Indian BRS. They do not have a lot of papers for them, but still BRS is essentially in these type of cases, without increasing the metal, more metal inside the artery. If you use a BRS, that can help you to gain the lumen. And I can tell you, I have got an experience of 4 or 5 BRS in all of them are absorbed in acute in instant restenosis. I can tell you that BRS has a potentiality to expand the lumen rather than anything else. So when you check the angio, check with the angio, this ISR after 1 year, you will see that there is a huge lumen acquired by the BRS. So I think these 3 learnings we have learned from your case.
I think you're absolutely beautifully put all these learnings. The first thing I would say is that the stent was definitely undersized.
Yes,
the first stent was severely undersized, and that is the beginning of the problem.
Yeah.
And as we have seen, that angiography is actually so deceptive.
Sir, I saw the angiography, sir. First, I could not get the proper this thing, CD to load, sir. But I saw the angiography. This was a case of anterior wall MI. It was 100% blocked, sir. So
Yeah,
they
so
have
during
undersized. Yes, sir.
during a acute MI, we always know that you can be undersizing the stents.
Yeah.
So that is one of the
They
reasons.
didn't do
But
proper
being LAD,
pre-dilatation.
being a LAD, to undersize a stent will cause these kind of problems.
Yes,
That is
sir.
for sure. So if it was a circumflex artery or even an RCA, that would have been different. But LAD, I think you need to be very kind of liberal with sizing of the stent. Particularly, this is a kind of a mid proximal to mid size. That is where the first problem started, undersizing. And then, as you can see, the rest of the problems kind of cascaded. And I think, as Dr. Shubhanan Ray mentioned, that the correctness of your procedure should be maintained while you are dealing with kind of the instant restenosis, ISR cases. The concept of BVS in ISR, I think this is something which we need a lot of data to validate exactly how good it is. But conceptually, it sounds good, because as Dr. Ray correctly mentioned, that the metal load is going to be much lesser. My concern is, again, you are left with, again, an undersized stent inside. So that is something which is an area of concern. So whether the BPS, after it got absorbed, whether size of the artery actually increases to the size which is required, that is something which we need to look into. Can I ask you that why did you use both IVL and cutting balloon in this case?
The IVL and cutting balloon. First, I used scoring balloon, sir. I was not
scoring balloon, yeah.
So first I started with the scoring balloon itself, sir. And because normal balloon was slipping, sir.
Yes.
So after that, melon seeding was there. So after that, sir, once I achieved some luminal area, after that, I used a 2.75 mm cutting balloon, sir.
Do you have any concern, Dr. Munga, in actually doing a OCT without dilating these kind of tight lesions?
Sir, I did the OCT first without dilating only.
Yeah, that's what I mean. Do you have any concern about the catheter actually going through easily, or do you really pre-dilate sometimes?
I use the extra support wire, sir. With that, it tracks, sir.
Okay,
so
you don't usually pre-dilate before doing a OCT if the lesion is very tight?
That if it is crossable lesion with the OCT catheter, then I don't pre-dilate, sir.
That makes a lot of sense, actually. So ISR is something, I think, as Dr. Ray mentioned, that the imaging is a must now. Without that, you'll never know the extent of the problem, the etiology of the problem, and with that, you cannot actually cure the problem. So, what did you do with the dissections which you had later on? What do you think was the dissections were there? What was the etiology of those dissections? Distal to the stent.
Distal to the stent, sir.
Yeah.
Sir, maybe, sir, wire or some OCT catheter, sir. That's only those two crossed, sir. There's nothing else crossed behind.
Can I make a comment here? There is
yes.
In OCT, sometimes minor dissections can be seen very easily. So not all dissections should be treated, which is seen in OCT. This is a basic teaching. If you see that the media is involved, or if the arc is more, then more than 65 degrees, then I think a stent or a balloon should be put, and that I mean dissection should be treated. Otherwise, smaller dissections, I thought it was a smaller dissection, it could be, you know, left alone.
Yes, it was smaller only, sir. It just did dab, sir. That's all. And very small size dab, sir. 2.5 into 20.
But I think the OCT criteria for treating dissection is definitely different from the one you do angiographically. Because angiographically visible dissection is definitely much severe compared to the, as Dr. Ray mentioned about the OCT dissection. So you have different gradation of dissections detected by OCT, when to treat and when to leave it alone. So I think this is important learning. So Dr. Ray, I mean, this neointimal proliferation and calcium, how often do you see this in ISR?
Basically, a drug-eluting stent ISR is generally focal. And in most of the cases, that the Ron-Oxman series, you will see that in most of the cases, in 48% of the cases, there is either a calcium behind the stents, and in other, next common is the stent start fracture. These two are the very common cause of ISR in drug-eluting stents. And now these drug-eluting stents, as they and particularly if they are not underexpanded at that point, maybe due to you know, more balloon dilatation, more or I mean very high pressure balloon dilatation, there is some disruption of the starts and the polymer, leading to intense inflammation, and that gives rise to new atherosclerosis. This is one of the theories of Renu.
Okay, sir.
Yeah. Actually, Dr. Monga actually has a beautiful series which he has published, the observational study, where he has taken subjects below 45 years of age. I think this is one of the topics we have discussed, myself and you, in one of these meetings, where these young SCS patients below 45 years, he took them up for angiography and saw thrombus, and then actually did OCT, and then could leave them alone. 85% of the patients were left alone, ultimately without stenting, and only 14% were, I think, stented. Please just tell a little bit about these cases, Dr. Monga, and then we can discuss a little bit. It's such an important topic.
Yeah, very important.
So that when I joined, sir, in Chandi Mandir Command Hospital, sir, I was getting a lot of young patients. And during that time only, I got the OCT machine, sir. It was in 2019, back in 2019, sir, when I got posted there, sir. I joined in September, and OCT machine came to me in November. So after that, sir, once I started, I used this OCT machine in PGI also. I've seen a lot of operators using, sir, Dr. Rajesh Vijayvargiya, Dr. Reddy. So after that, sir, when I started, I just started with initially with 2-3 cases, sir, first, because I didn't have many catheter. So in that I saw, sir, because many young patients were coming from the Leh Ladakh area, especially that Galwan belt. Lot of deployment was there of army, sir, at that time. So so many patients were coming with young patients with MI. They didn't have risk factor. Most of them were non-smoker. And just only risk factor was they were posted in a high altitude area for more than 3 months or 6 months. So that was the only risk factor. And they also found to have polycythemia. Average HB was more than 17 only, sir, in all these patients. So after that, sir, when I did the first, I was using thrombosuction in every case. But later on, I made a protocol that I'll be using, sir, intracoronary TPA, 1/10 of the systemic dose. Or if it is not available, TPA is not available, then I was using tenecteplase, 1/5 systemic dose. So I use 8 mg tenecteplase or 10 mg of TPA, sir, in these patients. So after that, I used to do check angio after firstly 3 days, but I was finding a lot of thrombus still there. So still imaging was not perfect. So after that, I started doing imaging and check angio after 7 days, sir. So at that time, most of the thrombus had already cleared. So now I could see there is no plaque rupture or anything behind that stent. So for the reason for putting a stent. So that's why I stopped putting stents. So now I done follow-up for more than 2 years for these patients, sir. And total 119 patients in the first year we got, sir. And we did OCT in 59 patients of these patients, sir. And all these patients did follow up, sir. And they're doing fine, sir. This after 2 years of follow-up.
Yeah. Your comments,
Yeah.
Dr. Ray?
A remarkable series. I must congratulate Monga for his wonderful, case series. But again, if I would have been there, I would have suggested one thing. The dose of tenecteplase, I used to do a lot of deferred AMI, and there the dose of tenecteplase is slightly higher. It is 5 milligram tenecteplase intracoronary for 5 and wait for 5 minutes and repeat the dose. This is 1/4 of the dose, total dose of tenecteplase. So we used to give 5 at least 3, sometimes in most of the cases 15 milligrams of tenecteplase. In that case, next day we used to do angiography and IVAS, and we saw that thrombus is not there. And basically, but the point is, in most of them there was a lesion in our cases because they are atherosclerotic. But it is so remarkable to see that only polycythemia being the risk factor. Can it be due to in situ thrombosis? What is this? We need to see that. Is it a thrombus somewhere and through the interatrial septal, PFO, it is going into the left side and going into the coronaries, or it is an in situ thrombus? These are the areas should be interrogated, and these are the questions which remain unanswered.
Dr. Ray, during this COVID times, we have also seen, Dr. Monga, you must have also seen that a lot of young individuals without any predisposing factors, they have come in with acute coronary syndrome, even with myocardial infarction, and just ballooning it, and the thrombus was gone with no residual lesions, and they were put on this kind of antiplatelet agents intravenously and brought back into the cath lab and seen that there was no requirement for stenting. So post-COVID era also, we are seeing a lot of kind of ACS coming in, even sudden cardiac deaths of so many people. This is unexplained for so many young, supposedly fit people who are just suddenly dying while on a treadmill or doing a gym. So these are the areas I think which needs to be looked into, because I think reflexively putting in stents for occluded lesions is something which will probably go out of vogue once with the imaging validating these kind of cases. What do you think, Dr. Ray?
It's an excellent, point, as because in all our cases of tenecteplase we did during the heavy COVID time. At that time, there was little young, they're all relatively young patients, and in COVID we did not know what will happen to the stents. If I put a stent, what will happen during COVID? The patient will die, leave. Or so we used to do. We used to put the IC tenecteplase and come out, and we thought that it is due to in situ thrombosis. But I don't know what is the etiology really. It is a huge area which remain unexplained.
Dr. Monga, your experience during COVID times, because these patients were coming September. Your series were between September 2019 and I think just after the COVID started.
Yes, sir.
These patients.
It was from September 2019 to October 2020, sir.
Yeah.
So that was the period I took for 55 patients did OCT, and otherwise total 190 patients, 119 patients. And most of these patients were from high altitude, but they were COVID negative, sir. We were doing COVID testing.
Yeah. So I think these are the very interesting subsets of patients who do not have coronary risk factors, but have propensity for clotting, like the one which you have a polycythemia, the blood clotting. In COVID, we know that they have propensity for clotting. So clots can cause MI, but it doesn't have to be a rupture of plaques always. So the particularly young patients, I think the point which your study will probably bring up is that for all young patients, we need to wait and not reflexively stent them. Because if you stent a young patient who is 30, 35, we get a lot of Bangladeshi patients who have actually atherosclerotic problems. We know that. And we used to, stent them. And we used to put long stents in them. But nowadays with ACS and the non-STEMIs, with young patients, we need to be careful while actually evaluating these kind of lesions. And I think this kind of strategy, it is probably not established yet, but I think we need a lot of data, and probably things are going to change in due course of time. So very well done, Dr. Monga, and we would like to see you more in our OCT forums and with your imaging data. And we wish you actually that we can always visit your center to see sometimes how you're doing. And I would also ask Shubhabrato to, if we can arrange an OCT symposium at your center, and we'll be very glad to join you. So as we move on to our next speaker, Dr. Shumanto, he's just joined us, and he's, as I just mentioned, Dr. Shumanto Chatterjee. He's senior interventional cardiologist at AMRI Hospital, Dhakuria, and he's going to talk about one of the exciting PCI case. So over to you, Dr. Shumanto, for your presentation. Could you please share this screen, please?
Thank you, sir. Sorry.
Yeah, we can see your screen. If you just maximize it.
Okay, thank you. Okay, good evening, everybody. So today, interesting case that a life-saving coronary intervention. One case is there. So just 2 days back, this patient, a male patient with known diabetes and hypertension, uncontrolled diabetes and uncontrolled hypertension, having 69 years of age, presented in the emergency with ACS and blood pressure 90/60. That is cardiogenic shock. Patient is drenched with sweats. He is having chest pain for last 12 to 14 hours. ECG showed STT changes in anterior leads. There is no STEMI. Not STEMI, there is an NSTEMI, and tropi was around 6.7. The tropi was positive. Echocardiography was done in ear itself, and it showed 35% ejection fraction with apex grossly hypokinetic. We then and there started the noradrenaline and shifted the patient to ICC. So we, I mean, patient is a poor patient with scheme patient basically. And we counseled him, explained the thing that NSTEMI patient with 12 hours or 14 hours chest pain is going on. Blood pressure is now 90/60. Patient relatives are saying that patient is having decreased urine output. I mean, not past urine since onset of chest pain around 10 to 12 hours. We put a catheter, and maybe 30 ml or 40 ml urine, dark color urine appeared. So we know that this is a case of NSTEMI, late presentation, cardiogenic shock, AKI. This is a bad substrate. So we explained that, I mean, even in advanced center, the mortality rate is still high in 2023. So we'll put the patient in heparin first, and loading dose was given. We wait for 2 hours because patient relatives were, I mean, very much taken aback with this poor prognosis kind of thing, and potential but was there. So we explained that if we do not intervene right now, the patient may, I mean, we may lose him. So this is angiography. See, we can see that patient is on adrenaline, noradrenaline. Left system, left LMCA, osteal. There is a disease. We do not know that if there is a thrombus lying over there, or there is a calcific plaque in LAD osteum, LMCA osteum. Bifurcation, LCX osteal disease, followed by TIMI2 flow in LCX. LCX is total cutoff probably. I mean, the artery in the groove is totally cut off. There is a OM1 is taking charge of this L6 territory, and it is around 90% diseased. LAD osteum is around 80 to 90% disease, followed by a small ectatic segment, and then again there is an 80% disease. From mid part, from osteum to mid part, LAD is diffusely disease. Distally, there is occlusion of LAD. Distally, there is no visible LAD. There is a big diagonal. Diagonal osteum is also 70-80% disease, and diagonal in the proximal part, and it is also in distally there is a total occlusion of the diagonal, and diagonal is also diffusely diseased. So it's a bad subset we know here. RCA, I mean, right dominant circulation is there. There is 30-40% eccentric lesion in the RCA proximal region, and there is an around 70 to 80% lesion in crux, and there are multiple PDAs are there, and PLV there is an around 80% lesion. We are not focusing on RCA right now. We know that there is an NSTEMI, anterior AMI, 35% ejection fraction, AKI, cardiogenic shock. We have to deal with the left system. So we again counseled the patient relatives that this is a very grave situation. Ideally, and bypass surgery would have been the better choice, but as the patient is in cardiogenic shock, it will be too much risky. So cardiothoracic surgeon was called forth. We discussed the case with the relatives in cath lab that this is the situation here. Around 30 to 40% mortality rate is there. Bypass surgery is an option definitely, but bypass surgery risk is more in this 70 years old man with uncontrolled diabetes mellitus with AKI and probably a history of a TIA 2 years back. So there is a chance is bleak in bypass surgery. So we convinced that probably we need an angioplasty right now, then and there. But there is a financial crunch. We know here that upfront IBP we have in our setup IBP and ECMO, all the things are there, but because financial issues are there, we cannot support him in IBP or ECMO. We have IVUS. This is a case if we land up in doing in the left system, definitely, and there is an LMC lesion and IVUS. Any form of imaging is at most important, but they don't have that much backup support, and this skin patients do not give us, do not allow us to use imaging techniques. But anyway, patient is crashing down, drenching sweats are there. We need to, go forward. So here one Schönblue wire is passed in the LAD, one wire in sinus, because we know that we have to little bit cautious and expedite the case, otherwise we may lose him. On noradrenaline support, adrenaline infusion is also started because pressure went down further. So we took a 2x10 NC balloon. There is NC trach from Abbott, and dilated the LAD ostium and LMCA. So after passing the wire, there's complete shutdown of flow in the whole left system. So we are very much skeptical whether we can go ahead with the balloon or not. But anyway, patient survived that the initial insult, and we escalated the balloon from 2 to 2.75. It's a new NC balloon, NC Traveler from Abbott, and it passed LMCA and LAD ostium. That part only we just dilated. So because there is a time is a crunch, if we dilate the whole LAD, and if there is a dissection and if there is a wire comes out, then we'll land up in problem. So we decided to go for LMCA ostium to LAD proximal part. This will stent first and see what's happening out there. If we lose the LCX or there is some untoward events, then what should be our further strategy? We'll next decide. First, we'll stent the LMCA to LAD and see what's the flow. So this is a 3.5 into 28 abluminous stent from LMCA ostium to LAD proximal part. The result was not bad. Patient was tolerating that thing. LCX is flowing. Then we pass the balloon down in 2 into 10 NC balloon, and whenever we just pulling out the balloon, wire moved out, little bit wire moved out, then there's a dissection, then we rewired it, then escalated the balloon from 2 to 2.5 into 10. Next we tried with 2.5 into 40 abluminous stent for the distal LAD, but it was a mistake kind of thing in this situation. In this calcific lesion, we couldn't cross the lesion with 40 stent. So we had to use a smaller size stent, that is 2.5 into 24 for the distal LAD. So here we can see the flow is there. So we stented the distal segment of the LAD with 2.5 into 24 abluminous stent. With that stent, we pre-dilated the middle area. Next, we again tried with 2.75 that NC balloon with for the middle part, and then again we tried that 40 size stent to cover up the middle one, but again we couldn't negotiate. So here we can see and then again we took two smaller stents, that is 2.75 into 24 and then 3 into 30 the abluminous stents. So covered with 4 stents, and then we dilated the whole territory with 3 into 10 NC balloon, and the LMCA was dilated with 3.5 into 8 balloon. This is the final result. We can see here LMC is covered. We don't know basically. I mean, ostium is covered, but how much the hanging part in aorta? We had a suspicion that but for that we need a IVUS, but patient we had to do it within 20 to 25 minutes. So we cannot afford IVUS that time. So we, as the patient was, little bit of improve after that thing, chest pain little bit decrease after 10 to 5 minutes of doing this, the whole procedure. So we thought that let the patient breathe, let the patient leave first. After 2 to 3 days, patient is still admitted in a hospital. So we thought that, okay, after 2 to 3 days, when patient will somewhat settle down, if the patient at all settles down, then we'll put the patient in a cath lab again to see the IVUS strategy of the ostium is missed or not, LMC ostium is missed or not. Anyway, the thing was dilated thoroughly with 3.5 into 8 balloon. So after 2 days, now the patient is off adrenaline, but patient is on noradrenaline support. Patient is maintaining blood pressure is around 110 by 90, 110 by 70. Patient is producing urine. Creatinine came around 2.2 in the first day after the angioplasty was done, and now patient's creatinine is 1.8. No dialysis was required, and we are tapering of the noradrenaline. Today is the 3rd day, and after noradrenaline, we can take off the noradrenaline maybe after say another couple of days, maybe Monday. Tuesday, when again put the patient on cath lab to see what is the amount of stent, what is the overlap, and LMC ostium was covered or not, this kind of thing. So thank you, and wait questions now.
Yeah, thank you, Dr. Chatterjee, for this excellent presentation. I'll hand over the mic to Dr. Suhanan Ray for his comments. There are a lot of things I think we need to discuss on this case. Okay.
First of all, we should congratulate him for taking such patients with energy, and the right thing to do, because we all know that in cardiogenic shock, if you can open the culprit artery, then the chances of survival is more than 50%. So the point is, there are a few important points which needs to be discussed. First of all, a patient who has a normal, who is a stable rhythm and having some amount of contraction and is responding to inotropes, at the beginning of the shock, IABP would have been a choice, definitely.
Definitely, sir.
And but in our country, or sometimes due to economic constraints, we cannot use that. So there, where we cannot use a mechanical stabilization, circulatory stabilization, and there our job should be very fast and crisp. You have done the right thing, but there are a few important points which needs to be impressed upon. That is, number one is, do not underestimate angiography. Angiography can rightly say whether your stent is at the left main ostium or not. It is much better than IVUS to determine where the stent should be put. IVUS can tell you what would be the size of the stent and what would be the deployment status, whether it should be more dilated, whether it is optimum. That can be assessed by this thing, IVUS. But IVUS cannot say whether you have put the stent at the ostium or not. Ostium is from angiography. A true angiographic view, cranial view, or a small LAO with a cranial view can show you the ostium, and you can place the stent at the ostium. This is number two. Number three, the stent size should be smaller in these critical patients, because you should have to stent only the required areas, because once there is after a few days, if there is a restenosis, it would be absolutely difficult for a surgeon to put a graft across. So, and also, if you increase the stent length, there is a much higher chance of stent thrombosis. And it is not easy to put a long stent evenly deployed in an artery. in a thrombus containing artery. It is not easy. So it should be at the right place where the maximum stenosis is. I would have put the stent from the proximal LAD to the LMC ostium. A very short stent. Number 3 is when you do a left main, always put a wire in the circumflex. Otherwise, if you're, and particularly in a case where there is probably thrombus, and once the thrombus is put inside a side branch, it is absolutely difficult to regain flow in the side branch. So always put a wire so that you can dilate to the balloon, and even you can use a thrombosuction to pull out thrombus from there. So these 3 are the very important findings, I think. Otherwise, I must congratulate you for taking such patients with energy and all, so that more patients can be survived and saved.
Thank you, sir.
Dr. Chatterjee, another point, I think I wouldn't touch the patient right now anymore. I mean, if anything needs to be done, let it be done when he's stable enough, I mean, you have just crossed a very important part of his life, given him the life back. So I think right now to intervene again, even if the check, I don't think that will be very prudent as per me. So I think if he waits for a month or a half, 6 weeks to 8 weeks, it will not cause any difficulty. Suppose I'm telling you that if you see that the ostium is not covered, you don't want to do anything right now because it'll be too risky for somebody to do it. That's number 1. That is one of the points which I thought. And secondly, I think the role of cardiac surgeon in this kind of case is actually 0. There's nothing to discuss.
Absolutely.
Maybe it's a medical legal requirement, but I think it is only a theoretical discussion because there's absolutely nothing he can do about this. And the only chance, as Dr. Ray mentioned, is to open the culprit artery, and that is only his best chance. You touch him with a knife, with the blade, he's not going to make it. And no anesthetist in his right sense will actually put this guy on anesthesia. So medically also, I think in a cardiogenic shock with this kind of profile, I don't think the requirement is there for a cardiovascular surgeon to even think about putting his mind into this. That's number 1. And I think it is a very case which has been very well done. The only thing which in our hospitals, we have a policy in this cardiogenic shock case. I understand the constraints of the cases where the finances are an issue. You have scheme patients, but I think Dr. Ray will agree that we can put pressure or negotiate with our administration that we don't do this every day of a year.
Definitely.
So once in a while, I think
the
balloon thing should be allowed. That things I think you need to negotiate beforehand. That I mean, this is the kind of thing which you as a department, I think you can actually negotiate these things, because here I think the issue could have been the turning point that you inflate the artery and there's no flow and there's no backup of a balloon pump. The patient will crash just because of that issue. So I think this is something which, as cardiologists, as I think people who are in the profession, we can negotiate. We have the seniority now. We do so many cases.
Yes,
I think as a group, we can always discuss this. What do you think, Dr. Ray?
Absolutely. That is the reason, and in the recent also, though all the trials did not show a benefit of IABP and even Impella in cardiogenic shock. No, and even ECMO, no one is helpful. But we know that the initial periods, during the beginning of the shock and sky shock A, B and C, early C and B, IABP is of real helpful. IABP is real beneficial, and we can call it a poor man's Impella because IABP produces the same effects what Impella does, but in a lower degree. And as there is a stable rhythm, and IABP would have done make your life easier.
Yes,
so what Dr. Binayak Dev said is a very valid point, that we must go to our administrators to allow at least in sick patients to use IABPs.
Definitely. So regarding the left main ostium, sir, I mean, there's a osteal plaque, and I meticulously, I mean, followed in 2 or 3 sine view. But after deploying, I had a doubt that probably I missed the ostium.
No, I can tell you
Just
what
the
you do.
ostium, but in probably no hanging struts in
No,
air.
don't hang your this. Why? Why you do not? We do not hang. Why you do not hang? You see, when you put your stent at the LMC ostium, you have to put the marker of the stent at least one lip of the LMC. Now you deploy. Now, when you post-dilate the stent, at least do a pot, the stent will elongate and it will come and cover the ostium.
Cover the ostium.
And all, if you make a huge hanging, then it will be hanging more inside the, this
Aorta.
thing, aorta. And next time, if you want to go to the circumflex or any branches, it will be absolutely difficult. Every time you will go through the starts.
Yes, sir. And
Because I think the ostium of the LMC is elliptical. It is not a circular thing. So we think in 2D it is a circular thing, and in 3D it is actually elliptical. So one strut, if it is hanging, if it is put in the inside, it will once you post dilate, you do a pot, it will actually cover it.
Yes, sir.
So, but in this situation, I think this is absolutely impossible to do it. So I think it's a question of chance what you got it here. So don't worry about it. The result is good. Patient is alive. So just let him go home. Let him come back after 8 to 10 weeks and just do a check angio and see. I think things are going to be fine. Because if he has survived this, I think he's going to survive it.
Yes.
So I think it's a fantastic case for discussion. And I think I really congratulate you and your team for pulling off this kind of case. And so much of adversity against you. The hands actually tied to the back. You really did this case. So many congratulations, Dr. Chatterjee. As we move on to our next speaker, Dr. N.G. Azam, who is Associate Professor of Department of Cardiology, National Institute of Cardiovascular Diseases, Dhaka. He's a very well-known personality in Bangladesh and Southeast Asia. So I would like to invite Dr. N.G. Azam to start his deliberation. So over to you, Dr. Azam.
Sir, Dr. Ajam is joining. Just he has some little bit network issue. He just communicated me. He needs few minutes to log in because he's just connecting through his laptop. But there is some network issue in Bangladesh right now. He is waiting for this presentation for a long time. So just give us.
Okay, we'll do some discussion. No issues at all. So we will do that.
Thank you for your kind cooperation.
Yeah. So we'll do a little bit of a discussion. So I think, Dr. Ray, what is your experience in this cardiogenic shock? I mean, what kind of output or the mortality incidence that you have in patients with cardiogenic shock going into angioplasty, or you could not take them up for angioplasty? We know the mortality is very high.
I know, and that basically mortality is very high, and all depends on the type of blood vessels we are dealing with. I have seen that in the mortality is better in STEMI than non-STEMI. The rightly timed STEMI is better than non-STEMI. In non-STEMI, there are a lot of arteries which cannot be, opened with balloon, and sometimes there are intense calcification, diffuse disease. So these patients have huge mortality. But the point is, in cardiogenic shock, what my experience is, it should be remembered that the stent size should not be very long. If you use a long stent, the chances of stent thrombosis is very high. And we have seen that good outcome. The patient has come out of inotropes. The 3rd day or 5th day, suddenly he had a heart failure and died. So stent thrombosis should be avoided. And also in STEMI patients, you have to remember that first 24 hours is very important. Sometimes I have, in my experience, 2 cases where I came out of this cardiogenic shock. After 24 hours, one patient had a BSD, and another patient had a cardiac rupture, and he died. And the BSD, I sent it to some other place for surgery, and he did not survive. So these are the issues, and also when your contrast should be very less, and you have to after the stenting there is a lot of work to do. The critical care work, the maintaining the circulation, the maintaining the urine volume, reduce contrast-induced nephropathy. There are so many things. It is not just an angioplasty. It has got so many other things which needs to be monitored.
Okay, there's another issue, which is $1 million question, which there are a lot of data on it also. When you are dealing with a patient with cardiogenic shock, Dr. Ray, do you believe are you a proponent of doing culprit lesion only, or do you believe in multi-vessel stenting?
No, it is culprit lesion. Absolutely culprit lesion.
Okay, we'll
multiple lesions,
patient guidelines are, changing, and once they say this, and then next year another study are saying that kind of.
So far, when we started at time, sometimes it was said that the total revascularization is better, but the culprit shock trial, it showed definitely that the culprit artery angioplasty is better than complete revascularization, because the patient made you just have an anatomically beautiful result, but the patient will die of contrast nephropathy. So it makes no sense. And we are now the complete versus incomplete revascularization in STEMI. They always talk about there is various gray areas. They talk about the stable patients first. Number two, if the patient can tolerate the culprit artery, and if you are assured that you can do the non-culprit easily, you can do it. Otherwise, you go by staged. So again, we have passed so many stages. Initially, it was culprit only, then total revascularization, then staged revascularization, now culprit again. So this is moving. It is moving like this,
Dr. Monga, your opinion on this subject, we would like to hear.
Yes, sir. So recently, I just wanted
the culprit or total?
Sir,
What do you believe in?
Culprit only, sir. Culprit.
Culprit only.
Contrast-induced nephropathy is the real concern, sir, in these patients. So
Okay.
I've encountered one patient recently, sir, and we could not save because it was a left main stent thrombosis of recently put.
I think, Dr. Monga, Dr. Chatterjee, myself and Dr. Ray, we are from the era of the 90s of angioplasties. So we actually believe that no angioplasty is actually easy. So
Absolutely.
if we believe that, that you do the culprit and the other looks a very juicy lesion, which will be done in 5 minutes, that is possibly true when the patient is stable. But in an unstable patient scenario, one single injection can actually put your patient into heart failure straight away. So you never know that the artery which you have opened now, whether that flow is actually taking effect immediately or not. So maybe your supporting artery, which has a lesion of 90% maybe, is still the artery which is actually causing the patient to be alive. So if you close that artery even for a few seconds, your patient might completely decompensate and go into a cardiac arrest situation. So I think I'm not a proponent of total revascularization. I believe in staged PCI in cardiogenic shock. You open the artery, culprit artery, you win the game on that day and come back and then wait. Dr. Chatterjee?
Yes, sir. Again, we are landing on culprit only. So first culprit, then complete, then staged, and then culprits, as Dr. Roy was saying. But they are saying that complete revascularization not on the first stage. You can complete the revascularization within the first hospitalization. It's 7
days. 3 days, 5 days, 7 days.
Now
yes.
They are 7 days kind of thing. First culprit, and then look for the cardiogenic shock and all those things. When the patient is dischargeable, then you can do the next. Or the patient still is in shock after 3 days, then you can rethink about this thing.
Because we have seen, people, cardiologists who do not have so much of experience in dealing with, unstable cases, that they think that, it is a 5-minute job. The other one, say maybe a proximal RC or something. But that might be the artery which is actually making the patient survive.
Yes.
You have opened the LAD, but it will take some time for the LAD territory to get perfused and stabilize the patient. So I think even if I think it should not be a knee-jerk reaction. I think if we follow the protocol, as you rightly said, We're not talking about on-table total revascularization. We're talking about in hospital.
Another important thing, sir, that we see that if this cardiogenic shock patient develops slow flow, patient was, flowing artery, there is a plaque and there is a thrombus kind of thing. We put a stent, post dilate it, and then slow flow develops. And this is detrimental. Whatever we do, adenosine and all those things, slow flow is not that much recovered. Around type, TME1 flow is recovered. In that case, we see that RWMA and patient's recovery is late. So do you, do you have any notion that we should not post-dilate kind of thing in cardiogenic shock? Just
No. Point is not that.
Recovers and then post-dilate it, this kind of thing.
No, so point is, in that case, you can refer to deferred STEMI trial. The deferred STEMI trial was that, and if you see a huge thrombotic burden, we just open the artery with a balloon and wait, and then you put a stent later on. So but the deferred STEMI did not, it was not successful.
It's not a success.
It was not successful. But yes, slow flow is a problem. But without post-dilating, if you see that your stent has not opening, it is also important. Important to post-dilate. So
I think, Dr. Ray, I think we as interventional cardiologists, dealing with cardiogenic shock and slow flow, we understand that if we have done your maximum, I think we need to leave it alone. We cannot chase a flow because there's nothing in the world which will improve the flow. That is number one. Number two, angiographical slow flow, which we see, actually, it is much better actually on ground. What happens, because if you leave this slow flow alone, sometimes after doing your maximum, I've seen that patients actually do recover, maybe a little slow, as Dr. Chatterjee mentioned. But these patients, if you try chasing it, you'll land up into bigger problems. I've seen people putting in more stents and more stents and more stents.
No, slow.
Actually, that is absolutely wrong
approach. It is harakiri.
It's
if
harakiri.
You put a stent in slow flow, it will be harakiri. That is not the point.
Yeah. Okay. Thank you, Dr. Chatterjee. I think we'll move on to Dr. Azam, who's just joined us. So just a minute. So Dr. Azam has just joined us now, and just introducing Dr. Azam. He's Associate Professor, Department of Cardiology, National Institute of Cardiovascular Diseases at Dhaka, and he's a very well-known person in the field of interventional cardiology in Bangladesh and in Southeast Asia. So we actually welcome him to our show. And Dr. Azam, we invite you to give your presentation, where Dr. Shubhanan Ray is going to be our expert panelist, and we have two co-panelists, Dr.
Can you off your
strategy? Over to you, Dr. Azam.
Yeah, can you off your screen and then I can share my screen?
Yeah, we can hear you, Dr. Azam. Shubhabrata, can you share Dr. Azam's screen, please? Shubhabrata?
Yes, sir.
Yeah.
Prasanjit, can you please help?
Just 1 minute. I'm trying to share my screen.
Hi, sir. Now you can share your screen.
Yeah. No, it's gone now again.
Yes,
sir, your screen is visible. Yeah, you can carry on. Go ahead.
I'm trying.
Your screen is visible, sir. You just play the presentation and go ahead with your presentation.
Yes. Wait, it's opening.
Yes.
Okay. Actually, I am connected with you hybrid mode in my.
I think,
computer
Roshanji, why don't you share the screen, and Dr. Azam will tell you how to move the slides.
But that is okay.
Yeah, please do that. You open the screen, open the slides, and Dr. Azam will guide you when to move the slides.
No,
Okay,
sir,
sorry.
Dr. Azam has the slide in his own laptop. Actually, I don't have the access to his presentation. Dr.
Okay. Is it visible?
Yes,
no,
it's
sir.
visible, sir.
Okay.
Visible.
Actually,
just click on the presentation.
Yeah, sure. Okay. And now I'm doing my computer and talking with my mobile because it is okay. Thank you, everyone. I'm sorry for late. Actually, I was badly stuck in cath lab. Again, I have to rush to cath lab, so I just go for quick case. Actually, the 42-year gentleman had a history of MI 4 years back in Oman, and now he presented in our center chronic coronary syndrome, CCS class 3 angina, and he had a history of PCI, attempt PCI, failed PCI in Oman. That's why he came into Bangladesh again for PCI. So we carried out his angiogram. If you look at this RCS total occlusion, left system is okay. So we planned for actually intervention. And if you look at this, left system is okay. Can you hear us? Can you hear me?
We
We
can hear
can
you,
see
but
your
we cannot
slides,
see.
Dr. Azam.
Yes. Can you see slide?
No, we can't.
Share the screen, sir.
Yeah. Just a minute. Why not? I already shared.
Sir, you have to click it. You have to open it, sir. You have to open it. You
No, I
just
think
shared,
I
but it is
think
not open.
he's actually seeing it his own laptop, but it is not being shared for some reason. Is it possible,
Yes.
Dr. Azam, that you email the slides to Prashanjit? Subhabrata, can you organize that?
Okay. Can I send it to?
Yes, yes. Now
Yeah,
it's
we can see it
yes,
now.
yes,
We can
yes.
see it now. Yeah, we can
Yes,
see
yes,
it.
now we can
Please,
see that.
sir.
Now we can see that.
Okay.
Yeah, please
Okay.
please
Now it
maximize
is
it
very
and we can
visible.
see. Yeah, we can see
You
it.
can see it. Okay.
Yeah.
Yes, sir.
Okay. This is actually RCS CTO. I just go to straightway go to the case.
You
Actually.
just make it full
And
screen,
this is
sir.
their left
Your
system.
slide is visible. You just make it full screen, sir. Your slide is visible, but it is not moving. The videos are not running. You just make it full screen. On right side, you can get a button. If you click there, the slide will be visible. Slide is visible, but the video will be running. Then everybody will understand the actual angio image.
Yes.
On the right side, the full screen. Yes, sir. That part. Just double click it.
Double click.
Yes, sir. Double click, then it will make full screen. Or you can play the image from there also.
Yeah. Is it okay?
Not now, really, sir. Or you can just go to the.
Sir, you can go ahead. You can go
Okay.
ahead.
I just send it to WhatsApp in to you. You can run it. Okay.
Okay. In the meanwhile, I think you can start talking about it and show the slides one by one. We can still see the slides. Even if the video is not moving, it's okay.
Okay, I'm sending it to 1 second. So I send it to you. You can open it.
Oh, yes, sir. I'm just checking.
You open it and you can share. Then I can talk in by mobile. Okay.
Okay. Just a minute, sir. It is getting downloaded. You can start briefing. By that time, I am sending it to my IT team, sir. You can start your pitch. By that time, I am sending it to my IT team.
You can give a brief briefing about the case, Dr. Azam. His connection is a little bit of an issue.
Okay.
It is getting downloaded. Once it's downloaded, I will send it to.
Okay, I just brief my case.
Yeah, please do the briefing of the case.
Okay.
In the meanwhile,
So just you it is a 43-year gentleman had a history of MI 4 years back in Oman. Now present in our center, CCS class 3 angina, non-diabetic smoker, and he again they present to we arrange a angiogram. System is relatively good. There is no significant disease in left system. So actually we planned for CTO and we try to open it up. By this time study is shared or not? I'm not sure actually.
It's not shared.
Not shared. Trisho, can
We
you
have
join?
yes, sir. I have sent it to my IT team. They are sharing, sir. By the time you will just give me a couple of minutes. So by the time he will do that.
I just now we have to show the. Can I? We can stop our screen share. That's just, then he can join. Stop sharing. Stop sharing. Stop. So that we ওখানকার থেকে ওরা জয়েন করতে পারবে। Actually, I'm in outside my office. That's why it is a problem. It is my chamber. That's why I can't arrange this total program. By this time, I can talk with Dr. Shubhanand Rai. Can you hear me,
Yes, sir.
Shubhanand Rai?
Yes, sir.
Thank you very much. Two to three of my fellows visit your center and they
Yeah.
meet with me. They really appreciate your support.
Thank you. Thank you. It is my pleasure.
You are always committed to serve our people. Thank you very much. Trisho, can you join? Share slide.
Sir, I have sent it to my IT team. They are doing, sir. They are doing. Shobroto, I have sent you the slides. Please play it from your system. You are sitting with IT. Shobroto, am I audible? Please play it. What I have shared to you. Please play it.
Subroto. Yes.
Shobroto.
I think Shubroto is connecting.
Yes, sir. Shobroto is sharing, sir. Shobroto is sharing. I have shared. He is sitting with IT. Shobroto is sharing. Yes, sir.
Prasanjit, please share the VA PPT.
Just a minute, sir.
Recording in progress.
Shubroto, anything wrong?
No, sir. Hello.
Please confirm. Doctors are waiting. Prasenjit, Shobroto. Yes, the slides started sharing. Yes. Dr. Azam, the slide is visible. Now you can start your presentation. Dr. Azam, the slide is visible. You can start your presentation. Dr. Azam, are you audible?
I think he is not audible. So,
Go brother, can you look into the matter? Okay, I think I got a message from Shubhroto that probably there's a challenge in getting internet connection back. So what are you going to do? Can you just change the
Hello.
slide?
Can you
Yes,
change
yes.
slide? Slide show.
Yeah.
Show.
Yes, sir. Yes, sir. They are doing. Prosenjit,
Hello.
just follow Dr. Azam's instruction. Go to the next slide. Yes,
Yeah,
Dr.
this
Azam,
is-
you can start. Thank you. Yeah.
Okay, this is RCS CTO. So please go to the next slide. Okay, next. Okay, next. Okay, actually it is RCS CTO. So we are planning to treat this RCS CTO. Next slide, please. Next slide. Next. Okay. Actually, okay, next. Okay. So we score IGC2 score, it is actually 3. And next slide, please. As because the blunt end, and this is the progress CT score actually we found. Also, it is you just found we found it is 2. So next, please move. Please next. So in just back. Okay. The proximal cap was ambiguous and lesion length was more than 20 millimeter, and distal vessel caliber is good, and collateral intervention septal collateral is very poor. There is no calcification. So our plan actually is integral approach. So next slide, please. Next slide, please. So next, first to change pilot student with photo, please. Next slide. Okay, then we able to cross it, and we are in the true lumen, just be dilated by 2 balloon. Then next slide, please. Next slide. Next slide. Okay, next slide. Then next. Then we just distally implant a stent 2.75 32 and proximally we plan 3 into 33. Okay, then next. Sorry, please back. Yes, you run the video. Okay, next. Next slide. So actually, patient we treat and we kept we send the patient CCU with DAPT. Second, the patient actually party complaining disorientation and weakness of the left limb, and we go for CT scan. Next slide, please. And we found there is a huge intracranial hemorrhage. Please. Next slide. Okay, next slide. And we just talk with the neurologist and neurosurgeon, and we stopped DAPT immediately. We started dimodipine and paracetamol. Next slide, please. And just we open it, then patient was extubated third POD and no collection after 6th POD. Then we start again 7th day, clopidogrel and aspirin. Plan for 1 month DAPT, then reassess. Please. All of you know the theory, 25% case, actually complex PCI or CTO like that PCI may coexist with his bleeding, high bleeding risk patient. Please, next slide. And if it is no high bleeding risk, but complex PCI, it is wise to continue longer duration. If it is high bleeding risk, there is no benefit actually longer duration of DAPT. Next slide, please. Okay, next. So all of you know the DAPT strategy. Next slide. So next slide, all of you know. Okay, next slide. Okay, next slide. So actually, what I want to discuss with this case, actually, this is CTO case, and we started DAPT. The second day patient developed actually intracranial hemorrhage. Actually, what should we do? That's why I just present this case for discussion. Shubhananda, I think you can start the discussion.
Yes, that's a very good case, and CTO with a can I just have a call from ICC? Can I just take the call and join again, please?
Sure.
Sure.
Please. So anyone can start the discussion.
Dr. Chatterjee, Dr. Munga, do you make any comments? Dr. Chatterjee?
Shubhra Banerjee or anyone can join.
So am I audible?
Sure.
Yes, you are.
So it's an excellent case, and ideally, I have seen that the retrograde collaterals was not very, very faint and broomstick-like. This is a little bit fuzzy. Usually they do not go easily. So retrograde is my last, bastion maybe. So antegrade wear escalation and antegrade dissection and re-entry. These two are the viable alternatives. So people have, people rely most on antegrade dissections because it is easy. But in our country, we cannot afford that. So in most of the cases, we go by antegrade wear escalation. And Dr. Ajam has nicely crossed that lesion, though there was a side branch loss, but it was the PDA is recovered, so it's okay. Now the problem is why that patient had a bleed. Ticagrelor is, we know that ticagrelor is very powerful antiplatelet drug. But the point is the patient's age is 43. He's
only
young.
43.
Only
Right.
43. But due to some unknown reasons, maybe there are some factors like von Willebrand factor and others that might be deficient. So there may be bleeding with ticagrelor. And in that case, there was a cerebral bleed which was nicely managed. And in a CTO, I cannot stop DAPT for a long time. we need to give DAPT. But nowadays, with the ultra thin stents, 1 month DAPT perhaps is enough. After 1 month, I would have put just one clopidogrel instead of clopidogrel aspirin.
So your recommendation is ecosprin and
Clopidogrel for 1 month, followed by clopidogrel only.
followed by clopidogrel what year?
For one antiplatelet drug, not
But
dual.
SAPT for the remaining, right?
uh.
So any actually, I think it is a young patient, maybe congenital arteriovenous malformation, may be one of the reason. I don't know actually, but we don't have any evidence by CT. So, but our discussion point is CTO is integrated always preferable, no doubt about this. But we did it. I don't know why the first time they failed. Probably they failed due to angulation. Probably I'm not sure actually. So it's okay, but DAPT issue is the main important issue.
Major issue.
Major issue in that particular case because they already evidence of intracerebral hemorrhage. So my plan also, just 1 month ecosprin and clopidogrel. Rest of the time we should continue clopidogrel only. So
What is the stent? What stent did you put?
distal stent is it is elite and proximal is Giants Expedition 333 and distal is 275/32.
Though in HBR patients, the majority trials were with the ultra thin stents.
Ultra
But,
thin stent, right.
Like
I do agree.
But Giants is okay. We do not have any data that Giants could not be used. Giants could be used because it is the ideal stent that has been ever produced.
Right.
So, but the thing is, nowadays, most of the studies are done by Onyx. Number one
Onyx
is
one and global one, yes.
Global one.
And
just tell me.
Master DAPT also tried by Ultimaster. Right.
And also there is a newer stent which is which do not have a polymer, and they have a drug to hold the sirolimus drug, that is Vivo. We call it Vivo. That is, this stent has got a probucol, and which is acting. Probucol is a drug which was used initially for anti-cholesterol, but nowadays this probucol coating on the stent that causes an effect like polymer, and they hold the sirolimus, so that it causes least amount of because there is no polymer, least amount of reaction with the vessel wall. And they are coming out with a big study of HBR where they show that 1 month DAPT is enough. So these are the newer generation stents. Perhaps they would be preferable, but still Giants could be used. I think Giants is a very good stent.
Good. So thank you. Actually, I'm sorry. Actually, I apologize because I am connected by mobile to talk and to see the computer. So synchronization and slide is controlled by Calcutta. So it is very difficult to synchronize.
Anyway, thank you very much, Dr. Azam, for your presentation. And I think we'll close the session now. It has been a wonderful session. We had Dr. Sumanta Chatterjee talking about the patient with cardiogenic shock. We had Dr. Monga talking about a case of instant restenosis, which was actually PCI'd with a done with a OCI guided. And we had Dr. Azam talking about a CTO. And on top of it, Dr. Shubhanan Ray gave his excellent comments as an expert as usual. So it's my pleasure to close this session and wishing to see you again in some session again. So thank you very much, Dr. Ray and Dr. Azam, Dr. Chatterjee, and Dr. Monga.
Thank you very much.
Thank you very much.
Coordination.